Hello and good morning to all. I'm Dr. Abhishek Singh from the Department of Oral and Maxillofacial Surgery, and today I'll be discussing about wound healing. So I'll be just giving a brief about the introduction. Wound healing is an coordinated response that involves cellular and subcellular responses to the tissue injury that leads to release of cytokines and growth factors, cell activation and resultant tissue degeneration. So whenever there is a wound, it has to heal. So there are always two forms of healing which can occur. Either it can be in acute form or chronic form. So acute is basically traumatical. You can get trauma to him. You can get a surgical area and a surgical wound is there, and you go for an incision, or there is a pathological wound. And when you come to the chronic, it's like a delay healing in this chronic phase. Like it's like 10 to 15 days that makes to a chronic wound healing. So I'll be coming about some injuries. Like if there's a surgical wound, it is basically intentionally created by a surgeon. So it is held in an operating room environment. So it varies in the degree of contamination. It depends on the anatomic location and the presence of local microbial flora. So subsequent to healing, that is affected by the level of cleanliness which is there present in the operating room. Then coming on to the traumatic injury like road traffic accidents or any injury which is like fight injury that is leading to a trauma. So that has to heal also. So it is caused by basically blunt or penetrating injuries and results in tissue lacerations, abrasions or even avulsions. Other mechanisms like tissue exposure to extremes of temperatures, radiations, caustic chemicals if you apply some chemical like burn injuries and all, and denaturing proteins. So these are the basic mechanisms which can occur in traumatic injury. Coming on to the pathological injuries, it caused by due to neoplasms and non-healing ulcers can cause tissue disruption, skin breakdown or ulceration that are secondary to ischemia, and traumatic handling of tissues during treatment includes crush injuries and desiccation. Now there are some phases of wound healing. Like when your wound heals, there are some phases in which the wound heals. So first phase is your inflammation phase. The second is your proliferation, and third is the maturation phase. So in these three phases, the wound heals. So coming on to the first phase, that begins at the time of injury. When your injury occurs, till for the third to fifth days of the injury, that is the phase of the inflammation. So vasoconstriction it leads to vasoconstriction in that initial area. Whenever there is an injury, the vessels around the injury it constricts, it leads to vasoconstrictions and release of catecholamines and prostaglandins. Platelet releases interleukins, tumor necrosis tumor growth factors, platelet-derived growth factors, and vascular endothelial growth factors, potentiating platelet activation and aggregation. Coming on, afterwards, first is there vasoconstriction, afterward leads to a vasodilation, which leads to vasodilation and inflammation following hemostasis. Chemical mediators cause leukocytes and plasma proteins to permeate the wound. Endothelial cells drastically change the shapes, become rounded. You know about the endothelial cells? It is the basic line of the lines. The lines are basically ciliated columnar, but afterward it becomes rounded whenever there is an injury, creating gaps within the vessels so that there is leakage of plasma and fibrogen. It leads to increased vascular permeability, and it leads to the clinical findings such as there are 4 to 5 inflammatory signs, that's Galler, Ruber, tumor, dollar. So these are the 4 signs. Galler means Ruber means redness, Galler means increased rise in temperature, and tumor means there is swelling there. So when the wound heat and redness are a result of vasodilation. Pain causes by vasoactive amines and pressure from edema protects the site from further tissue injury. Then during the first phase, there is neutrophil concentration which peaks by 24 hours. Like there's an injury, after 24 hours there's an increase in neutrophils. First sign of action. The neutrophils are also called as the first injury. Whenever there's an injury, the first cells or the first the warriors basically, they are the neutrophils. Collagenases, elastalases, and cathepsins and bactericidal cationic proteins are released from the neutrophil granules. And monocyte concentration, that is also leading to increase But after 24 hours, the first 24 hours there will be increase in neutrophils. But after 24 hours, like 48 to 72 hours, there will be increase in monocytes. Uh, there is a diagram, doll. I cannot show you the diagram, but you can tell. I can just tell you. Then first is the second is the first I told about the inflammatory phase. There are two things in the inflammatory phase. There's an injury. First signs of actions are inflammatory phase. Inflammations basically. All the inflammation starts. And first signs of cells are neutrophils. They come after 21. That's the first thing you should remember. The second thing is the monocyte concentration. The monocytes increased. And then comes the proliferative phase. You know, in the endothelial cells there was gapping, so that there is a leakage of vascular permeability. There is increased vascular permeability. So in the proliferative phase, also known as fibroblastic phase, that is established after 4th to 5th day and in last 2nd to 3rd week. It is characterized by ingrowth and proliferation of granulation tissue. Granulation tissue, a loose connective tissue matrix which is formed by collagen secreting fibroblasts, supports neovasculature and inflammatory cells. Fibroblasts arrive at the wound on the 3rd day and peak concentration within the 1st week. And synthesizes mostly type 3 collagen. In the second phase, we are talking about the second phase, that is the proliferative phase. First is the inflammatory phase, inflammation occurs. Second is the proliferative phase, there will be proliferation of cells. The inner cells will proliferate more to make the wound heal. So that is the second phase we are talking about, where there will be increase in collagen type 3 synthesis. There will be increase in the proliferation of the granulation tissues. And it will be starting with a neovascularization, which enhances by the local factors such as hypoxia, elevated tissue levels, cytokines like fibroblast growth factors, vascular endothelial growth factors, and platelet-derived growth factors. Epithelialization promoted by extracellular growth factors and keratinocyte growth factors. These are the phases these are the cells which are proliferating right now. And in this phase, when we are talking about the blood vessel, there will be 3 phases in the blood vessels which are going in the proliferative phase. First will be the cells will migrate epithelially, so there will be migration of the cells. Then it will lead to proliferation and differentiation. The dermal layer is re-epithelialized and the contractile forces are exerted by the fibroblasts and myofibroblasts that aid in re-approximating wound margins. The skin graft open soft tissue wounds can limit to the amount of the granulation tissues produced, thereby reducing scarring and the tissue contraction. Mechanical strength of the wound increases through the proliferative phase. So in the first phase, there were 3 phases I talked about. The first was the inflammatory phase. The second was the proliferative phase. In inflammatory phase, the inflammation starts. The first neutrophil starts. Neutrophil starts to increase in the first 24 hours. But after 24 hours, there will be increase in the monocytes. So these are the cells these are basically WBCs, which are becoming differential leukocytes, which will be coming and to help or to aid the area which has been affected by the wound. The second phase will be proliferative phase. The cell will come in proliferation, will start to proliferate and start the wound healing work. So these are the things which will be going on in the second phase. And in this phase, the wound starts getting strength. The healing gets strength in this phase. So the dermal layer is re-epithelialized and contractile forces exerted by fibroblast and myofibroblast aid in re-approximating the wound margins. Then coming on to the third phase, which is the last phase. First was the inflammatory, second was the proliferative, third is the maturative phase. In the maturative phase, that is characterized by increased interwound tensile strength related to the increased collagen production and breakdown. Remodeling begins after the 3rd week. So in first 24 hours, there is the first, which is the first phase. There is the inflammatory phase. In that is extending up to 3rd day or 5th day. In 5th day to the 2nd week, basically 10-12 days, it is the proliferative phase. Now there will be the maturation phase. The proliferative cells will start maturing in this phase, which will come first after 3rd week. And in 3rd week it starts after the 3rd week after the wound has occurred or after the trauma has occurred. And from the 3rd week to the 6th week, that is the phase which is called as the maturation phase. The first, the inflammatory phase, 3 days, 0 to 3 days. Then 3 to 7 days or 10 days, that is the second phase, which is the proliferative phase. And after 10 days or after 2 weeks or to 3 weeks, till the 6 months, that is the 3rd phase which will be going, which is the maturation phase, where the cells will mature. So it is characterized by increase in the wound tensile strength related to increased collagen production and breakdown. Remodeling begins after the 3rd week and last 6 to 12 months. Initial scar tissue becomes stronger as type 1 collagen replaces type 3 collagen. Remember that in the second phase there were type 3 collagen which were increasing, but in the maturation phase there is type 1 collagen which is increasing. The augmented collagen deposition and subsequent collagen cross-linking increases scar tensile strength up to 75 to 80% of the pre-injury tensile strength. The tensile strength which was there at time of injury, which will increase in the third phase up to 75 to 80%. Tensile strength is defined as a load per cross-sectional area that can be supported by a wound. The increase in tensile strength is proportional to the rate of the collagen synthesis. The more there is a collagen, there will be more tensile strength. It is in the directly proportional. Like the tensile strength will increase as there will be increase in the collagen synthesis. So in this phase, type 3 is getting replaced by type 1, and as the tensile strength will increase as the collagen cells will increase, collagen synthesis will increase. So over the time, there is decrease in the number of fibroblasts and macrophages. Scar vascularity also decreases as tissue proliferation declines. So now the tissue proliferation is getting, the proliferative phase is getting subsided down, and the cells which are being proliferated, they are getting matured. So these changes are clinically correlated to a less erythematous, flatter and softer scar. So if this is basically this is the phases. These are the 3 phases of wound healing. So the first is the inflammatory, second is the proliferative, third is the maturation. So if the healing is not proper, then it is lead to abnormal healing, and abnormal healing leads to scar. So they can be 2 scars, like we have scars after the injury we get scars, right? So there can be 2 types of scars which comes under abnormal wound healing. So these can be keloid scar and hypertrophic scars. Keloid scars and hypertrophic scars are aberrant forms of wound healing that results in proliferative scarring. The keloids, they are benign growths. Basically, these are the tissues which have been healed. So the tissue which has been healed, but the healing is improper. The healing was improper. It has been healed, but it was improper. So it leads to a scar. So it is the keloid. First is the keloid scar. That is the fibrous tissue that has grown beyond the wound boundaries. Like this is the wound boundary, and if there's healing, this is the wound basically, and it has to be healed like that. So if the healing is not like this, and there's an immature healing which was occurring, so there will be increase in the tissues. The fibrous growth will increase. So this margin will increase to this part. So it will be like a bogey basically tissues. So it occurs mostly over the sternum area, earlobes, back trunk and the extremities. So it is like firm and rubbery, and it can be erythematous, painful, or it can be also prurient. It develops months after trauma, piercing and giving surgical incisions, and is caused by overproduction of connective tissues secondary to altered apoptosis or hyperproliferation of the keloidal fibroblasts. Treatment of this scar, like this, the scar which has formed improperly. So we can treat this also. The first line of treatment is giving an intralesional. I am talking about the treatment of the keloid scars basically. So the first line of treatment is intralesional injection of the corticosteroids into the scar to reduce the fibroblastic process. Like if there's a scar which is unhealed, which has been healed but it has not healed properly. It has been healed. So the first line of treatment is giving steroidal injections in that area where there is a scar is present. So it will reduce the fibroblastic production. Like collagen has been increased in that phase. Collagen has increased. So we give steroidal injection for the collagen to get reduced. The fibroblastic action gets reduced, and also the extracellular matrix proteins. So it localized pressure therapy, the second treatment. If we can give injections, steroidal injections we can give. The second thing we can give a localized pressure therapy to apply pressure on that area. Or if we can give fluorouracil in that area, that can be used in combination with the intralesional injections. It can also be used surgically, excised or treated with radiations, cryosurgeries or topical. Coming on to the hypertrophic scars, they have similar appearance but to keloids, but do not extend beyond the margin of the original wounds. They also appear shortly after the injury and may recede over time. Characterized by prolonged inflammation and collagen deposition, and it can be red, firm and elevated also. So So the treatment given the same as that was a keloid, like intraregional injections can be given, but the thing is that they can recur after the treatment. So this is the topic I was covering. So I talked about the tissue healing. What is the tissue healing? I talked about the phases of the healing, and if there is an improper healing, it can lead to scars. So it can be the keloid scar or hypertrophic scars. So thank you so much for the listening.